So this is what normal alignment looks like. If you see the red line which goes from the center of the hip to the center of the ankle, it normally passes through the center of the knee. Now what that means is 50% of the load is going through the inner side, what we call the medial side, and 50% of the load is going through the outer side or the lateral side. When a patient has bow legs, as you see in this picture, you will notice that the red line is going all the way to the inside of the knee. This causes overloading on the inner side. So now it's not 50% on the inner and the outer side, it's 100% load on the inner side of the knee. And the inner side of the knee was not meant to take so much load. So just like a car tire where the alignment is not proper, the tire wears out on the inner side. Here also the cartilage of the knee wears out on the inner side. So what do we do in a HTO or a high tibial osteotomy? We don't do anything to the joint. We don't replace anything in the joint. What we are doing is we are correcting the alignment. By correcting the alignment, we bring that red line which you saw, the weight bearing axis, back to the center of the knee, so that the load is now equally shared between the inner and the outer side. There are two ways that we do this. One is what is known as the orthofix fixator, which is an external fixator, and the other is using a plate inside. For the fixator, it's a metal part which is fixed outside the body, as you can see there. So we have 2 pins put into the bone close to the knee and 2 pins away. That is a X-ray picture of the pins in the bone above as well as below. And then we cut the bone, because unless you cut the bone partly, you can't change its angle. So the actual surgery or the actual cut just requires 2 stitches. Then when the patient comes out of surgery, the leg is exactly as it was before, in the sense it is still a bent leg. After a rest period of about 7 days, that fixator is gradually adjusted at 1 millimeter per day, and this is something that the patient does themselves at home. And over a period of 3 weeks, if you see the picture on the right, that angle has changed. Now this is a set of X-rays from before surgery to after surgery. And there's 2 things you will notice over there. One is that the axis has changed. 2, if you look at the inner side of the knee, where the red arrow is pointing, you will find that the joint now seems to have opened up. That gap between the 2 bones seems to be all right now. But what is most important is the 2 pictures on the right side. The picture which says 4 weeks overcorrected shows too much of correction. But because this is a fixator, this can be adjusted again to get the line exactly where it is. Now here you see a video of a patient walking 10 days after the fixator has been locked, which means about uh, a month, a little more than a month after surgery. So they are walking reasonably comfortably with a pair of crutches. Older patients may require a walker. And here you can see that over a period of 12 weeks, as you go from left to right, the first X-ray is at 4 weeks after surgery and the last X-ray is 12 weeks. This gap, because it was created or it was done at 1 millimeter per day, that is a gradual distraction, this fills up by bone by itself without any further sort of procedure. And once it is healed, I'll show you later that the fixator can be taken off. Here you can see different patients at various time periods in their treatment, how comfortably they are able to walk. The people walking without sticks are of course 2.5 months after surgery. As the bone heals, they are able to walk better. So now once the bone has healed, the fixator has done its job and we can take it out. So we take it out and there is nothing left inside. That is one of the advantages of using the fixator. You don't require any second surgery to take out an implant like you have in a plate. And the scars are all very small. Most people are not bothered by it, but if they are, then we can always do a little plastic surgery after a year or so, whatever scar is remaining. The other method is where we use a plate. The principle is the same, that we change the angle of the tibia, that is the leg bone. Only thing, instead of having a fixator, we have a plate inside to hold it. With a fixator we do this gradually. With a plate we do this on the operation table and fix it in that position with a plate. So there is no adjustment possible in the plate. So this is the kind of incision that is required, and these are the steps of the surgery. Here you can see that the bone cut is exactly the same as we do with a fixator, except that it's done through a bigger incision. That's another view of that. And then the bone is opened up. So we check the alignment after the bone has been opened up, that triangular part that you see, and fix it with a plate. So at the end of surgery, this is how the stitches and the alignment look. This is a closer view of the stitches, and this is the final picture for the patient. So you can see both are essentially the same. Here also you can see that the alignment has been corrected. The leg now looks straight. The only difference is that the fixator, we have the adjustability. With the plate we don't have that adjustability. Plus side of the plate is there is nothing outside to take care of it. And usually younger patients I will try and use a fixator so that I have a good enough correction. Now when can you start working with the fixator? Here you see a case with quite a lot of bow legs, and he had one side corrected and then the other side corrected, and what you see on the right is the final picture. Patients who have pain in both the sides, we do the surgery on both the legs within about 6 weeks or so of each other. We can also do it after about 3 months, once one side is healed and the other side is then ready for surgery. So here's a patient walking with fixator on both the legs. This is after one side fixator was removed. And this is after full correction. So she is now 6 years after surgery, and you can see that the gap and the alignment is maintained. She continues to be free of pain. So you can be active. This is one of our anesthetists who about 6-8 weeks after the first surgery was going out. She was working in the theater, doing all her regular activities. So now you can make a note of any further questions that you may have and discuss them with us.